Slide 1. This slide tape is one of a series of presentations in renal pathophysiology prepared by the American Physiological Society. 2. The program begins with a review of prerequisite knowledge. Before you go any further, make sure you have completed the entry skills test provided in the study guide. 3. During the presentation, question slides will appear at intervals. Stop the tape to answer the question. Then advance to the next slide on which the answer will appear. Stop the tape again to check your answer. After you finish the unit, assess your understanding of the material by taking the post-test in the study guide. 4. The subject of this discussion is hyponatremia. Content expert, Dr. Howard Frazier. 5. We will be discussing first the physiological mechanisms which determine water intake and excretion, and second, the major situations in which hyponatremia occurs in terms of 1. Mechanisms inducing water imbalance, 2. Their characteristic signs, and 3. Types of treatment. 6. Your first objective is to 1. Identify two components of a process taking place within the kidney by which constant osmolality of body fluids is maintained, and 2. List 3 factors which determine water ingestion and 4 factors which determine water excretion. 7. The term hyponatremia signifies an abnormally low concentration of sodium in the extracellular fluid. A decrease in the serum sodium from its normal value of 140 milliequivalents per liter to values below 120 milliequivalents per liter may result in seizures, loss of consciousness, and death. 8. The constancy of the total solute concentration of body fluids is due to a balance between the ingestion and excretion of salt and water. 9. Hyponatremia is a common and serious manifestation of disordered regulation. The ways in which it may develop can be predicted on the basis of the physiological mechanisms for the regulation of sodium and of water balance. 10. The balance between ingestion and excretion of fluid is maintained by the kidney. The ability of the kidney to regulate the total solute concentration of body fluids and thereby to preserve constant osmolality is achieved by an important process. 11. Solute is separated from water within the kidney, and the excretion of each is regulated independently. By understanding this process, the difference between causal relations and simple associations is clarified in those instances when disorders of solute concentration are contrasted to abnormalities of extracellular fluid volume. 12. Although some indirect connections between solute concentration and extracellular fluid volume regulation are found, hyponatremia can occur in individuals whose extracellular volume is either abnormally contracted or grossly overexpanded. 13. The kidney can vary the excretion of water relative to solute over the range of 50 to 1,200 milliosmoles per liter, and thus preserve the total solute concentration despite wide variations in the intake of water. 14. Total solute concentration of body fluids is measured as p-osm, or plasma osmolality. As mentioned previously, the constancy of plasma osmolality is due to a balance between rate of water ingestion and the rate of its excretion. 15. Water ingestion is determined by thirst, habit, and the urgings of health workers or prescription. 16. Water excretion by the kidney as a large volume of dilute urine depends upon 4 factors. 17. The first is the delivery of an adequate volume of salt and water to the ascending limb of the loop of Henle. The second is the integrity of the mechanism for active salt transport at that site. The third is the further reabsorption of salts of sodium in more distal portions of the nephron. 18. And the fourth factor is the ability to inhibit the secretion of the antidiuretic hormone ADH when P-osm falls by as little as 1 to 2%. 19. Failure of any of these 4 mechanisms reduces the ability of the kidney to excrete free water, that is, water unobligated by the simultaneous excretion of solute. This failure makes an imbalance between the rates of water ingestion and excretion more likely. 20. If the imbalance occurs, water will be retained. Hyponatremia results if water retention is not matched by equivalent solute retention, since the available solute in the body will be diluted and both P-osm and the solute concentration of cell water will fall. 21. Remember to stop the tape to answer questions and to check your answers. 22. 23. 24. 25. Your second objective is to 1. Describe the relationship between plasma osmolality and the concentration of sodium in the serum. 2. Identify 4 physiological events which result in release of ADH and may alter the balance between water ingestion and water excretion. 26. Up to this point, we have been using hyponatremia and reduced total solute concentration interchangeably. Some justification for this usage is required. Sodium and its anions, chloride and bicarbonate, make up approximately 90% of P-osm. Therefore, a significant decrease in P-osm necessarily involves a decrease in the concentration of sodium in the serum. 27. Note that although low P-osm is always associated with hyponatremia, a significantly elevated P-osm is not necessarily due to hypernatremia. Elevations of glucose and urea concentrations may be the source of the increase in P-osm. 28. In the normal regulation of water balance, a slight elevation of P-osm is a major stimulus for the secretion of the antidiuretic hormone ADH. ADH acts on the kidney to conserve body water. 29. In disordered regulation, several non-osmolar events occur which act to release ADH. This inappropriate secretion of ADH is inferred from the finding that despite a low P-osm, maximum urinary dilution is not achieved. 30. We now recognize that release of ADH occurs when there is a reduction in the degree of stretch of muscle fibers in the left atrium, or reduced arterial pressure, or reduced stretch of the arterial tree in the region of the baroreceptors. Stimulation of these receptors by inadequate vascular volume or failure of the heart as a pump results in water retention and a fall in P-osm. 31. Painful stimuli or frequently used medications such as narcotics may also cause the release of ADH. 32. When ADH is released due to a non-osmolar hemodynamic stimulus, concentration regulation is sacrificed in the interest of preserving an adequate or effective extracellular fluid volume. Although this regulatory priority has clear-cut adaptive value in the short run, in the face of continued intake of water, it may be responsible for life-threatening hyponatremia. 33, 34, 35, 36, 37. Our third objective is to 1. Identify the three major situations in which hyponatremia occurs. 2. Assign the appropriate cause to each. 3. Identify manifestations or signs. And 4. Suggest the appropriate treatment. 38. One useful way to classify the three major situations in which hyponatremia occurs is to first divide them into two categories. One that is associated with normal circulatory function, and the other associated with impaired circulatory function. 39. The category associated with impaired circulatory function can be divided into two classes. One associated with contracted extracellular fluid volume, and the other with abnormally expanded extracellular fluid volume. Expanded extracellular fluid volume, if severe, results in swelling of dependent portions of the body and is termed edema. 40. First, we will consider the class with impaired circulatory function and the group within it characterized by contracted extracellular fluid volume. When sodium depletion occurs, as it may with severe diarrhea, intense sweating, or injudicious use of diuretics, the extracellular fluid volume contracts. 41. If significant, the contracted volume is associated with a reduction in arterial pressure and a reduction in glomerular filtration rate. The decrease in arterial pressure may trigger the release of ADH independent of the level of P-osm. The reduced GFR decreases the volume flow of salt and water to the ascending limb of the loop of Henle. 42. Both the reduction in arterial pressure and the reduction in GFR operate to diminish the rate at which water can be excreted. If water ingestion continues at a rate greater than this new limit, hyponatremia must result. 43. Identification of sodium depletion as the cause of hyponatremia depends on marshaling the available evidence for contraction of the extracellular fluid volume. Decreased blood pressure, particularly when the patient is upright, increased heart rate, absence of edema, and often decreased tissue turgor. 44. In addition to reduced serum sodium concentration, laboratory confirmation includes evidence for a recent and usually modest reduction in GFR as given by elevation of blood urea nitrogen concentration or the level of serum creatinine. 45. The normal response to sodium depletion is renal conservation of the sodium ion. Therefore, the urinary concentration of sodium should be less than 5 milliequivalents per liter, unless the kidney itself is the root of the abnormal losses of sodium that resulted in contraction of extracellular fluid volume. 46. Since the diminution of the excretion of free water is ultimately the result of sodium depletion, restoration of normal capacity to regulate P-osm is best achieved by the administration of sodium. It is unnecessary to attempt an estimation of the absolute deficits of sodium and water. Repair of extracellular fluid volume by administration of isotonic saline will reestablish the operation of the normal regulatory mechanisms and result in prompt correction of the hyponatremia. 47. 48. 49. The second major situation in which hyponatremia occurs is characterized by impaired circulatory function associated with overexpanded extracellular fluid volume, usually to the extent that obvious edema is present. The impairment is commonly the result of serious cardiac disease or of severe liver disease and its associated complex combination of lowered serum albumin and redistribution of blood flow. 50. In either instance, the kidney has a diminished capacity to excrete free water. The first mechanism responsible for this diminished capacity is a decline in GFR, with a resulting reduction in the volume flow of salt and water to the ascending limb of the loop of Henle. 51. The second mechanism for the diminished capacity of the kidney to excrete water is recognition of the severely impaired circulation by the baroreceptors, which results in a release of ADH. 52. This secretion of ADH is termed secondary inappropriate release. Secondary because it is released in the presence of a physiological trigger, circulatory failure, and inappropriate because it is independent of piasm. 53. Disordered regulation of water balance results in the retention of water in excess of the volume appropriate to maintain the accumulated amount of sodium at a normal concentration. The mechanisms responsible for the accumulation of abnormal amounts of sodium in the extracellular compartment are described in another slide tape of this series. In disordered regulation of water balance, you should recognize two important features. 54. First, even though free water excretion is severely reduced, sodium is retained. Hyponatremia will result only if water ingestion is continued while sodium intake is restricted. 55. Second, circulatory impairment invokes a common set of mechanisms for the reduction of free water excretion: the decreased delivery of salt and water to the distal tubule, and the secondary inappropriate release of ADH. 56. Whether the hemodynamic defect results from cardiac failure or liver disease, the patients with impaired circulation and expanded extracellular volume are easy to recognize because of the presence of dependent edema. The physiological control systems respond as though the extracellular fluid volume were contracted. As previously mentioned, concentration regulation is sacrificed to the preservation of an effective extracellular fluid volume. 57. The hypothesis that hyponatremia with expanded extracellular fluid volume is due to inadequate circulatory function is supported, as noted previously, by the laboratory findings of recent and usually modest elevation of blood urea nitrogen or serum creatinine and a urinary sodium concentration of less than 5 milliequivalents per liter. 58. Our analysis indicates that water intake should be restricted in order to control the imbalance between water ingestion and water excretion. Efforts also should be concentrated on the improvement of water excretion. We lack available safe and reliable means of inhibiting ADH release or of blocking its effect upon the kidney. We are left, therefore, with the important and difficult task of improving circulatory function by treating the primary disease. 59. 60. 61. The third major situation in which hyponatremia occurs is characterized by normal circulatory function. Numerous etiologies have been identified, and we will mention only two: brain injury due to trauma or infection, and ectopic production of ADH by malignant tumors. 62. In this case, hyponatremia is due to the primary inappropriate release of ADH. Primary because it occurs in the absence of the physiological triggers we have already discussed, and inappropriate because the hormone is secreted independent of the level of P-osm. 63. The pathogenesis of this form of hyponatremia is most clearly shown in an experiment in which ADH is administered to a normal individual on days 2 through 4. Water is provided in amounts just sufficient to cover the total of insensible losses and the renal requirements for excretion of the load of solute at maximum urinary concentration, a total volume of perhaps 1 to 1.5 liters per day. Under these circumstances, the administration of large doses of long-acting ADH is without effect on the serum sodium. 64. The experiment is repeated, but this time water ingestion is increased to a level that is not unusual, but which exceeds the minimum daily requirement as defined previously. Under these circumstances, administration of long-acting ADH is associated with a precipitous fall in the serum sodium and a modest gain in weight due to the retention of approximately 3 kilograms of water. 65. The most obvious reason for the hyponatremia is that the available sodium is simply diluted by the 1/3 of the newly retained water that remains in the extracellular compartment. Although dilution plays a role, the observed fall in serum sodium substantially exceeds that which would be predicted on the basis of this mechanism alone. 66. The immediate explanation for the discrepancy is provided by observations of urinary sodium excretion. Even though the subject is on a constant intake of salt, urinary excretion rises to levels far in excess of intake as water retention occurs. The net loss of sodium in the urine makes the largest contribution to the development of hyponatremia. Our problem thus becomes one of understanding how the retention of 3 kilograms of water, of which 1 kilogram remains in the extracellular fluid, should induce this dramatic decrease in renal conservation of sodium. 67. Your familiarity with the factors responsible for the renal regulation of sodium balance might lead you to look first for increases in the filtered load of sodium brought about by an increase in the GFR. In fact, GFR does increase with increased cardiac output caused by the retention of approximately 300 milliliters of the increased body water in the vascular space. 68. Increased cardiac output has another consequence as well. You will recall from previous studies that intravascular volume affects the secretion of aldosterone, which is the sodium-regulating hormone. When intravascular volume and circulatory function rise, aldosterone secretion is inhibited and sodium is excreted. 69. In a subject with normal cardiac reserve, aldosterone release, determined indirectly from urinary analysis, shows that inhibition does occur during the phase of water retention brought on by ADH. Although increased GFR and aldosterone inhibition are the most completely documented influences on sodium diuresis, other mechanisms may be involved as well. 70. On the basis of the results of the experimental simulation of the pathogenesis of hyponatremia due to primary inappropriate release of ADH, you would expect to find that affected individuals had circulatory function which seemed normal to physical examination, or, at most, had a mild elevation of blood pressure. The volume of water retained in the extracellular compartment is below the limits of clinical detection, so edema is not found. 71. Laboratory tests show, in addition to the hyponatremia, a blood urea nitrogen or serum creatinine concentration that is within the normal range for that patient, or even lower than usual, suggesting an increase in GFR. 72. Urinary concentration is greater than the minimum to be expected if ADH had been inhibited normally by the low p-osm. Urinary sodium concentration, particularly during the development of hyponatremia, is higher than the 5 milliequivalents per liter we previously set as the upper limit when sodium is being conserved. 73. A number of programs for the emergency correction of hyponatremia due to primary inappropriate release of ADH have been suggested, none of which is without risk. For the purposes of our present discussion, we need only recognize that the key event in the pathogenetic sequence is water retention. Negative water balance is induced by stopping water intake, while insensible losses continue. Over a few days, this procedure will eliminate the causes of the renal losses of sodium and improve the serum level. Whatever the additional measures that may be undertaken, rigid restriction of fluid intake is the mandatory common denominator in management. 74. 75. 76. In discussing the pathogenesis of hyponatremia, we have placed particular emphasis on the circulatory factors which reduce the volume of fluid delivered to the loop of Henle and on non-osmolar stimuli governing the release of ADH. 77. These principles have permitted us to define and analyze 3 situations in which hyponatremia occurs: circulatory impairment with contracted extracellular fluid volume or with expanded extracellular fluid volume, and apparently normal circulatory function. 78. Although this list is not an exhaustive one, it includes the overwhelming majority of instances of hyponatremia seen in clinical medicine. Each is explicable on the basis of a few physiological principles that describe the way in which the solute concentration of body fluids is regulated. 79. This concludes the discussion of hyponatremia. Refer to your study guide for the post-test and references for additional reading.